Introduction. Welcome to this lecture on renal electrolytes and their disorders. In this session, we will explore how the kidneys handle each major electrolyte and what happens when their levels become abnormal. Let's begin. 1. Sodium, Na. Sodium is the primary determinant of extracellular fluid volume. Renal handling. About 65% of filtered sodium is reabsorbed in the proximal convoluted tubule, mainly through the sodium-hydrogen exchanger. 25% is reabsorbed in the thick ascending limb through the NKCC to transporter. 5% is reabsorbed in the distal convoluted tubule through the NCC channel. The remaining 3% is reabsorbed in the collecting duct by epithelial sodium channels, or ENAC, under the control of aldosterone. Hyponatremia, low sodium. Hyponatremia occurs when sodium falls below 135 milliequivalents. Common causes include thiazide diuretics, heart failure, cirrhosis, and excess water intake. Symptoms include headache, nausea, confusion, seizures, and in severe cases, coma due to cerebral swelling. Hypernatremia. High sodium hypernatremia occurs when sodium rises above 145 milliequivalents. It is usually due to dehydration, diabetes insipidus, or excessive salt intake. Patients experience intense thirst, irritability, lethargy, and in severe cases, seizures caused by brain cell shrinkage. 2. Potassium K. Potassium plays a vital role in neuromuscular function and cardiac rhythm. Renal handling. Potassium is reabsorbed in the proximal tubule and the loop of Henle. However, its main regulation occurs in the collecting duct, where principal cells secrete potassium under aldosterone control. Thus, aldosterone increases sodium reabsorption and potassium secretion. Potassium hypokalemia results from loop and thiazide diuretics, vomiting, insulin therapy, or hyperaldosteronism. Symptoms include muscle weakness, fatigue, cramps, and life-threatening arrhythmias. On ECG, it shows you waves, flattened T waves, and prolonged QT. Hyperkalemia, high potassium. Hyperkalemia is caused by renal failure, potassium-sparing diuretics, ACE inhibitors, or massive cell breakdown, such as rhabdomyolysis. Symptoms include muscle paralysis, paresthesias, and dangerous cardiac arrhythmias. ECG findings show tall peaked T waves and possible progression to ventricular fib. 3. Calcium Ca². Calcium is essential for muscle contraction, neurotransmission, and bone mineralization. Renal handling. 65% is reabsorbed in the proximal tubule. 20% is reabsorbed in the thick ascending limb. 10% is reabsorbed in the distal convoluted tubule under the influence of parathyroid hormone, which increases calcium reabsorption. Hypocalcemia, low calcium. Hypocalcemia occurs in chronic kidney disease, hypoparathyroidism, vitamin D deficiency, and after acute pancreatitis. Symptoms include perioral numbness, muscle spasms, and tetany. Classic signs include K-Vostek sign, facial spasm when tapping the cheek, and Trousseau sign, hand spasm with blood pressure, cuff inflation. Hypercalcemia. High calcium hypercalcemia frequently results from hyperparathyroidism, malignancy, vitamin D toxicity, and thiazide diuretics. Symptoms are remembered as bones, stones, groans, and psychiatric overtones. This includes bone pain, kidney stones, abdominal pain, constipation, and confusion. High calcium causes polyuria and dehydration due to nephrogenic diabetes. 4. Phosphate, PO4. Phosphate is essential for ATP cell membranes and bone mineralization. Renal handling. Most phosphate is reabsorbed in the proximal tubule through sodium phosphate catransporters. Parathyroid hormone decreases phosphate reabsorption, leading to increased phosphate excretion. Hypophosphatemia, low phosphate. This occurs in alcoholism, refeeding syndrome, hyperparathyroidism, and diabetic ketoacidosis treatment. Symptoms include muscle weakness, respiratory failure, and rhabdomyolysis. Phosphate depletion impairs ATP production. Hyperphosphatemia, high phosphate, most often caused by chronic kidney disease and tumor lysis syndrome. High phosphate binds calcium, causing hypocalcemia and soft tissue calcifications. 5. Magnesium, Mg². Magnesium is required for enzyme function, PTH release, and neuromuscular stability. Renal handling. 15% is reabsorbed in the proximal tubule. 70% is reabsorbed in the thick ascending limb. 10% is reabsorbed in the distal convoluted tubule. Hypomagnesemia, low magnesium. Causes include chronic alcoholism, diarrhea, diuretics, proton pump inhibitors, and malnutrition. Symptoms include tremors, tetany, seizures, and cardiac arrhythmias. Low magnesium can cause both hypokalemia and hypocalcemia due to impaired PTH secretion. Magnesia, high magnesium. Seen in renal failure, magnesium-containing antacids, and excessive for magnesium administration. Symptoms include loss of deep tendon reflexes, muscle paralysis, bradycardia, and in severe cases, respiratory arrest or cardiac arrest. 6. Chloride, Cl. Chloride closely follows sodium to maintain electroneutrality and plays a crucial role in acid-base balance. Hypochloremia, usually seen in vomiting and loop diuretic use, leading to metabolic alkalosis. This is because chloride loss increases bicarbonate retention. Occurs in diarrhea, saline infusion, and renal tubular acidosis, type 2 or type 4. This causes a normal anion gap, metabolic acidosis. 7. Acid-base and electrolyte interactions. Electrolytes and acid-base status are closely linked. Metabolic acidosis causes potassium to shift out of cells, producing hyperkalemia. Metabolic alkalosis causes potassium to shift into cells and increases renal potassium loss, causing hypokalemia. Renal tubular acidosis types 1 and 2 are associated with low potassium, whereas type 4 is associated with high potassium due to aldosterone deficiency or resistance. Conclusion: the kidneys maintain electrolyte balance through precise mechanisms of filtration, reabsorption, and secretion. Understanding these pathways helps in diagnosing and treating the various electrolyte disorders seen in clinical practice. This concludes the lecture on renal electrolytes and their disorders.